Okay, and so for the interest of time, hi everyone, thank you for joining us for this session, Characterizing Patient Encounters of Opioid Use Disorders in the Midwest. I would like to start with a couple of reminders. This session is recorded and will be available on the conference platform 1 hour after the session ends. Please keep yourself muted unless the presenter asks otherwise. Make sure to join sessions live today because we will be doing a prize drawing from attendance within each session. The conference is also offering free continuing education credits. For more information, visit the continuing education page. And I am very excited to introduce Dr. Yu here. He will be going ahead and introducing our team of presenters.
Yeah, Lisa, let me share my screen. Can everyone see my screen?
It told me I didn't actually need to do it, but when I had my last surgery almost 3 years ago, it took me almost 2 years of PT.
Sounds like we might need people to mute if they're not.
Hi guys, just
presenting.
remember to go ahead and mute when you enter. I will be trying to catch them as they come in, presenters.
All right, let's get started. Good morning, everybody. I'm Dr. Yifei Liu. I'm an associate professor at University of Missouri, Kansas City, UMKC School of Pharmacy. The four presenters today include myself, Ms. Sahil, Dr. Farr, and Dr. Hagel. Ms. Sahil is the database architect at UMKC School of Medicine. Dr. Farr is the director of outcomes research at St. Luke's Health System in Kansas City. Dr. Hagel is an associate research professor at UMKC School of Nursing and Health Studies. The four of us has formed a small research group in Kansas City with research interest in addiction science. Our group's specialty is retrospective analysis of secondary database. We appreciate this presentation opportunity to talk to you about our research and also introduce what databases are available for potential collaboration at UMKC. The topic of today's presentation is characterizing patient encounters of opioid use disorders in the Midwest. Patient encounter is a term associated with a database we used. Basically, it means a patient visit to a healthcare facility. For example, an inpatient stay at a hospital or a visit to an emergency department is a patient encounter. This study is a subgroup analysis of a larger study which examined patient encounters of opioid use disorders in 3 census regions. That larger study was led by me and Dr. Hagel. Ms. Sahil and Dr. Farr served as consultants. Before I move on, I want to mention that there are handouts available in the portal for this presentation. We acknowledge UMKC Collaborative Data Science grant program for supporting the larger study. The context of the grant was that Dr. Hagel and I, along with external investigators, were interested in developing a network of recovery support services research across 3 census divisions. Those divisions include Division 3, East North Central, which includes Illinois, Indiana, Michigan, Ohio, and Wisconsin. Census Division 4, West North Central, which includes Iowa, Kansas, Minnesota, Missouri, Nebraska, North Dakota, and South Dakota. And Census Division 7, West South Central, which includes Arkansas, Louisiana, Oklahoma, and Texas. For this presentation, it was a subgroup analysis focusing on the Midwest, including census divisions 3 and 4. There are two parts in today's presentation. The first part is about the study itself. Dr. Farr will present the section of introduction. Then I will present the sections of objectives, methods, and results. Next, Dr. Hegel will present the sections of discussion and conclusions. Ms. Sahil will present the second part, which is an introduction about secondary databases available at UMKC School of Medicine. Probably the second part is of more interest to you because of knowing the database availability can facilitate potential collaboration. After the second part, there will be a Q&A session. Now I will hand it over to Dr. Farr.
Great. Thank you, Dr. Liu. So hi, everyone. My name is Stacey Farr. So here I'm going to kind of talk through the introduction background. So, the surge of opioid use disorder over the last 2 decades has led to serious challenges in how the U.S. workforce responds to the epidemic. The current addiction treatment delivery system, it has been unable to adequately respond to the opioid epidemic. The U.S. Surgeon General advocates for a comprehensive approach, including improved access to evidence-based treatments. And these include, medication for OUD or MOUD, integration with mainstream health in emergency departments, and recovery support services or RSS. Peer-based recovery services or RSS is the process of giving and receiving non-professional and non-clinical assistance to achieve long-term recovery from substance use disorders. Now we can go to the next slide. And, what we used was William White's framework, which is also known as the recovery-oriented systems of care model. And this looks at recovery-focused performance measures in 3 different domains or dimensions of evaluation. So the first is thinking about long-term recovery outcome measures, and these include things like citizenship or lifelong learning and purpose, resolution of drug and alcohol problems, and global, including physical, social, and emotional health. The second are measures of infrastructure and stability, for example, and adaptive capacity. So these include like an organization's capacity to undergo system-level changes. And then the third are these recovery-oriented service process measures, including things like identification, engagement, and retention, more of the process measures. And many studies also have been showing a growing efficacy of RSS models in achieving better health outcomes. And to kind of look a little bit into the literature, here's a summary of a few things looking at various opioid use disorder outcomes. And so, the first article here is Schieber et al. And they're all with the CDC. They published a paper in JAMA that's looking at prescribing patterns by states. It did lack some like clinical data, but this study, what they did was use the primary outcome of looking at prescribing patterns. And they did a cross-sectional analysis to kind of look at that variation in prescribing patterns across states. The second article here, the Haffagi et al. In 2019, this is from researchers at the University of Michigan, and they published a cross-sectional analysis looking at county and national mortality data to see if outcomes of opioid high-risk counties, to see, if counties had, for example, higher than normal opioid mortality and less than normal rates of provider availability, then they would be considered opioid high-risk counties. Zhang et al. In 2020 from Penn State, they used market scan commercial claims and looked at cross-sectional data or did a cross-sectional analysis to look at opioid use disorder prevalence among privately insured adults ages 18 to 64 in the US. And then Krazik et al. In 2020 at NYU and at Hopkins, were the two teams. They published an addiction looking at opioid overdose deaths. They were looking at before and after treatment and using statewide treatment data in Maryland linked with death records. And, to really kind of summarize this body of literature, and especially of recent, there's been a lot of national interest and importance around understanding geographic variability on a number of opioid use disorder outcomes. So these including prescribing patterns, mortality, provider availability, opioid use disorder prevalence. And we really need to kind of understand these factors that are driving opioid use disorder and how and why this differs geographically. And so from there, we can better, identify strategies to improve both the care and outcomes for individuals with OUD.
Thank you, Dr. Park.
Great. Sorry, is this me or you? I'm sorry.
Oh, this would be my slide.
Okay, go ahead. I apologize. Thank you.
Thank you, Dr. Park. So part one of the presentation has two objectives. First, we are going to characterize patient encounters of opioid use disorders in the Midwest using health facts database. The second objective is to compare selected patient encounter characteristics between two census divisions in the Midwest. So we are going to compare East North Central versus West North Central. And third objective would be part two of the presentation. So Ms. Sahil will describe secondary databases related to OUDs that are available at UMKC. We analyzed health facts database from 2010 to 2018. And to give you an idea about how large health facts database is, it includes 22 million hospital inpatient stays, 66 million emergency department visits, and 750 healthcare facilities. Later, when Ms. Sahil presents the second part, she will provide more details about this database. We set two inclusion criteria. First, adult patients who had an indexed encounter and who survived at least 30 days after the discharge. Second, the location of the encounter should be in the Midwest. The encounter of an OUD was defined as having a relevant ICD-10 codes as the primary discharge code for that encounter. The date at which a patient first had an encounter was the indexed date. As I mentioned earlier, the Midwest consists of two census divisions. Division 3, East North Central, and Division 4, West North Central. One advantage of using health facts database is that there is a long-standing UMKC Institutional Review Board IRB approval. The purpose of an IRB review and approval is to ensure appropriate steps are taken to protect the rights and welfare of study subjects. So for projects associated with health facts database, there is no need to file a separate IRB application. For the first two objectives, the unit of analysis was a patient encounter. That is, for a patient who visited a healthcare facility multiple times, each time was counted as an encounter. The variables we selected were on two levels, the patient level and the facility level. Patient variables included age, gender, marital status, race, length of stay, and patient type. Facility variables were census division and urban versus rural area. Some of these variables were continuous variables, such as age and length of stay, whereas the other variables were categorical variables. And we used descriptive statistics. For the second objective, to compare the two census divisions, we used the t-tests to compare continuous variables, such as age and length of stay. And we used the chi-square tests to compare categorical variables. And the raw data of health facts cannot be directly used for the study. They had to be transformed and selected through a data mining and data cleaning process. It was a critical but time-consuming process. The entire process of data mining included many steps. To show you an example of the data mining process, on this slide, I chose the part of how we selected patient encounters. A blue capsule represented either a start or an endpoint. We started with health facts database, and that step was not on this slide. A blue rectangle was a task. A blue diamond was a decision point. An orange folder was a document. An orange parallelogram was a database. A green circle was a data quality check. This partial process started with a document of data request sent to Ms. Sahil. In that data request, we put forward the instructions and deliverables. As you see, at first, the three sub-criteria, adult patients, patients who had an index encounter, and patients who survived after discharge, they were applied parallelly. However, the data set that was generated failed to pass the quality checks. So the data set was scrapped, which was shown as an endpoint. We found out there should be two decision points. First, whether the ICD-10 code of an encounter was a primary diagnosis. If yes, then the encounter was included. Second, whether the patient encounter had a discharge disposition as expired. If yes, it means the patient passed away and the encounter should be excluded. After that, then the three sub-criteria were applied parallelly. And then we got a valid data set. About results, a total of 55,400 patient encounters were identified in the Midwest. And 24% were in Census Division 3, whereas 76% were in Census Division 4. Among patient characteristics, those associated with the highest frequency were Caucasian, male, being single, and other patient types. For facility characteristics, I just talked about the proportions for the census divisions. In addition, urban area had a greater number of encounters than rural area. According to t-tests, compared with Census Division 3, Census Division 4 had a greater average age and longer average length of stay. And you can see the comparisons here. According to chi-square tests, compared with Census Division 3, Census Division 4 had a significantly higher proportion of patient encounters associated with male, African American, single, and rural area. In addition, Census Division 4 had a lower proportion of patient encounters associated with Caucasian, married, divorced, emergency patients, inpatients, and outpatients. Now I will hand it over to Dr. Hagel.
Thank you, Dr. Liu. So just kind of putting it all together, those results. First, I want to emphasize this was a large data set, and we really wanted to use this information for preliminary analysis of whether we could see this variability geographically. And as Dr. Farr pointed out, geographic understanding emerging patterns in substance use and substance use disorders is important to understand geographically. Also, we were writing a larger grant that involved these areas, but this was really the first attempt at utilizing such a very large database to characterize patient encounters in our region, the Midwest states. And I did put in the chat the census states and their breakdown. I have a hard time memorizing them myself, so I always refer to them, that we're in Division 4. So that's Iowa, Kansas, Minnesota, Missouri, Nebraska, North and South Dakota. And so this is exciting that UMKC and all of our associates and collaborators have this important data and information that we can utilize to strengthen our service delivery system ultimately. Next slide. So as Ife went over the results, we found that in our Census Division 4, where Missouri and Kansas lies, I assume that we're predominantly from Kansas, as this is a Kansas conference, or Missouri, since we're neighbor states here. There were a higher proportion of encounters and longer average of stay for opioid use disorders in our census division. So they were also prevalent, but more severe when we compared it to the other Census Division 3 in the Midwest. And in our census division, African Americans who are single and male and who lived in rural areas were at a higher risk for opioid use disorders. Now, you guys are all service providers. I doubt this is surprising to you from your actual day-to-day experiences in the service delivery, but this is important information because it does reveal a health disparity. Patients in Census Division Area 4, our division area, had less utilization of emergency care services, inpatient, outpatient services. So this, provides some evidence that we need to look at our infrastructure systems and do outreach to particular groups. Next slide. So in conclusion, we hope to publish these results found that census area 4 had more prevalent opioid use disorders that were more severe than census area 3 in the Midwest region, and that these comparisons of encounters revealed a health disparity and, access issues and other relevant systems issues that we know we're all aware of and want to address. Before I turn it over to Suman, we could take questions in the chat. We plan to take verbal questions at the very end, but if you want to put some questions, since we just presented the data in the chat, we'll facilitate them as well. But I do want to highlight two things. There is obviously, Ife went over that this data set was up to 2018. And so we're in 2021, there is a lag. And at this particular period, it's an important difference because we know that COVID only worsened the opioid crisis and the drug overdose crisis in particular. So we are hoping to look at the data, post 2018. The other big reflection I will make is that we live in the era of data, right? We're collecting data. My phone's collecting data on me right now as I'm sitting here. They know how long I've been in my office and, how many miles till I need to fill up my gas tank again. So what do we do with this data though? We want to make it meaningful so that we can improve our services. And this was our preliminary attempt at looking at this very large data set that was available to us with hospital encounters to understand, from some perspective of geography, what has been going on for individuals who are seen in emergency or seen in hospital systems for opioid use disorders. So that's the other big piece. How do we make our data more real time, of course, but also meaningful so we can make tweaks in our service delivery system. Okay, I will end there and turn it over to Suman. And again, we can take questions in the chat. And we will take, a discussion questions, and we can go back to our data set if you want to ponder that more at the very end. We'll leave like 10 or 15 minutes, I believe.
Hello, everyone. I'm very excited to present. Can you all see my screen here?
Yes, but you're not on slideshow display. Yeah. We're just seeing, okay.
I'll do that. Hello, everyone. I'm very, very excited to present this today. And I am excited to work with electronic health record in health informatics. My role is database architect at UMKC School of Medicine. Here. So we all understand the primary uses of electronic health record data that's used to support point of care decision, enable immediate access to documentation, promote compliance, protect patient privacy, automate and streamline clinical operations and billing. But there is meaningful secondary use of data to improve public health, reduce health disparities, safety, engage patients, improve quality and efficiency. Today, I'm going to present to you some national longitudinal data for clinical research, and that's Cerner Health Facts, Piconet CDM, and Cerner Real World Data. And I have been very blessed and I have built a good amount of experience in working with these longitudinal databases that carry data for almost 20 years from 2000 to 2018. Cerner Real World Data has data from up till current that's refreshed every 3 months, and Piconet CDM is across 12 networks, almost 70 million patients. So there is the technology definitely is very helpful in really analyzing this data well, and which can make the analysis easier for us to have insights into what's happening with clinical care. Health facts metrics as of November 2018, we have total patients of 69 million, 22 million inpatient encounters, almost 66 million emergency encounters, 431 million outpatient encounters across many geographical regions, which was a strength for this opioid study in specific. For example, Midwest, we had almost 177 facilities that contributed data. From Northeast, 235, from South, 263 facilities contributed data, and from the West side, 174. So in total, 750 facilities across 85 systems. And data has both person level, patient level, and site level characteristics that can be, that influences the outcomes. And it can be identified using the bed size, acute versus non-acute, teaching versus non-teaching. There is good footprint of data though. We have hypertension, cardiovascular, like for example, hypertension, 17 million, cardiovascular disease, 7 million, atrial fibrillation, 5.1 million, diabetes, 10 million. And there was a good amount, good aspect to opioid data cohort as well. It was pretty rich and well distributed across geographical locations. So it was a good resource to really study firsthand how the opioid crisis is going on in Midwest region. To give you a sort of highlight in regards to how the data is architected, how the data is flowing, and it's being so that it can be made available to researchers. So we have a data warehouse that houses data from Cerner and non-Cerner client. Why do I say non-Cerner client? Because Cerner was St. Luke's system used Cerner before, but now it's an Epic shop. So that way we still have St. Luke's data, but since it's in de-identified format and it's available for research purposes, so we do retain data from across 20 years from 2000 onwards. This data is it goes through strict quality assurance processes, and there is de-identification happening, data is being mapped, normalization happens, and data is made available in the data warehouse where it can be mined using SQL, R, or SAS. We used to have a graphical user interface I2B2, which could source in the data that belong to the Truman Hospital, and it could be seen through graphical user interface of I2B2, where the researchers could build the queries themselves with a drag and drop model. To talk briefly about Piconet CDM data, the Piconet Common Data Model is a specification that basically defines how data is stored, structured, and labeled for all Piconet sites. All Piconet sites use the Piconet CDM to store clinical data from the network. We have common acronyms, Piconet CDM or PCDM. So basically, what we are saying here is Patient-Centered Outcomes Research Institute, which funded the development of National Patient-Centered Clinical Research Network. It made it easier and more efficient for us to conduct research. So Piconet is made up of partner networks, basically, which harnesses the power of large amount of health data and patient partnerships. So these CRNs, or clinical research network, are one type of network that is supported by PCORI. And these CRNs consist of 2 or more healthcare systems. So the data that utilizes this Piconet Common Data Model, it's longitudinal data. It has empirical master patient index. We are able to connect multiple encounters to a patient and specific encounters for a patient across different hospitals. So data has quite a good strength, and we can track what kind of services have been leveraged by patient across different departments in a hospital. So we can conduct these longitudinal studies. To give you an idea about the strength of Piconet CDM, so Mizu is a partner in the Midwestern Piconet Center, and it's part of Greater Plains Collaborative GPC Network. So basically, GPC Network is 12 leading medical centers in 8 states, and now it's 9 states, which are committed to shared vision of improving healthcare delivery. So like University of Wisconsin, University of Iowa, Nebraska, Texas, quite many impressive names. And recently Houston will be joining us. So Piconet CDM suffices or presents many different categories of data across demographics, encounters, diagnosis, procedures, conditions, labs, medications, vitals, death and death cause, providers, patient-reported outcomes, immunizations, and address history. So almost 70 million in the network, and it represents data from everyday encounters with more than 70 million people across US. So to give you an idea about how the schema or the data model looks like, it has data spawned across different categories. Like I said, demographics, labs, vitals, and where you see these small boxes, they are belonging to each table. Data is de-identified. It has all the PHI has been stripped off the data. We are able to seek insights by connecting different fields across different tables in order to identify unique encounter or multiple encounters, or if all these encounters belong to this specific patient for these specific diagnosis, or apply the inclusion and exclusion criteria in real time. And especially for health facts, it's human, we do not, it has a common IRB, but for Piconet CDM, we need to submit an IRB just to be able to use data. We have access to MUHC, Missouri University Health Network data through Piconet CDM. Also, we could be part of the GPC network, which brings data from 12 networks across 9 states. And all of it is following common data model. So there are some benefits to using this common data model. It allows for distributed queries, reducing costs, allows for analysis of relatively consistent data sets across sites, and it covers broad range of commonly used data categories and well documented. And you could look at what does it comprise of, how is the distribution of data and patients across gpcnetwork.org sites as well. Some of the limitations are the characteristics of the electronic health record data. Like it requires someone like me to invest significant amount of time to maintain high quality and current data. And it does not contain all data elements a researcher might need. And there is some variability across sites. The third resource that I'm going to present to you is real world data. So since health facts data is till 2018, so Cerner came up with real world data. The data is delivered on a different platform, Jupyter Notebooks. So basically this data is made up of Cerner's Healthy Intent platform. It has electronic medical record and billing data, and it's accessed through Healthy Data Labs. The output is exposed through Healthy Intent and OMOP schema, and data is refreshed quarterly. So it is more current than health facts. So when we talk of OMOP schema, it's again a common standard data model. It's observational medical outcomes partnership, which allows for systematic analysis of disparate observational database. The concept behind this approach is to transform data contained within those databases into common format into common representations. We all know, since we are harvesting this data from multiple care facilities, so we want to standardize the terminologies, vocabularies, coding schemas, and then perform systematic analysis using library of standard analytics routine, and which can be written in common format. So basically, how this data truly looks like, overview of Cerner ETL process. So Cerner basically extracts data from a contributing Healthy Intent environment. It merges all of the real world data contributors into one data lake, and it deduplicates any duplicate record IDs shared across contributors, creating new real world data record ID in the process. It does de-identify both patient identifying information and hospital identifying information. So instead of using MRNs, instead of using the Social Security, it uses MRNs or database generated specific numbers. There is date shift, a consistent date shift, so the date difference remains consistent and maintains the meaningful use. At the same time, all the PHI is stripped of the data, so it can be HIPAA compliant and de-identified and can be used for the research purposes. It does pass through strict quality assurance, but still there are some limitations to the data, and I'll discuss that in further slides. To give you an idea about the data footprint for real world data, almost 87 million patient encounters, 14 billion lab results, and that's significant. 6 million microbiology results, almost 5 million like COPD encounters have been identified there. They have immunizations, especially in the COVID climate, almost 62 million immunization given so far. And it has quite a significant number of procedures and diagnosis. So I see a greater strength to the data. I have done many studies across data. So the cohort could be identified using ICD-9s, 10s, HSPC codes or CPT codes from the procedures or from the labs. We can use appropriate surrogates or placeholders if that specific data element is not there. The data is really fun to work with because we get good number of insights, especially for the longitudinal data across many years. So to give you an idea about different geographical locations, which has contributed data. So this slide suffices that need. And you can see certain percentage of data across different geographic locations. So Healthy Data Lab, like Dr. Yifei said, data mining, secondary analysis, transforming data so that it can give us the research insights or it is supporting or negating our hypothesis. It can be, it gets very time consuming, especially the transformations. Cerner has tried to make it easier, but because the data is so huge, still we need to do secondary analysis. Cerner is using Healthy Data Lab. So Healthy Data Lab is basically a collection of open source tools that are built within the cloud. So everything is going cloud these days. And these are made available to the users through a web portal. So the development environment for users to conduct this retrospective analysis and to identify care gaps and patient populations and much more. So we have a web portal and it's supported on the cloud. To give you an idea about these cloud services, Amazon Web Services, basically people talk about different terminologies. 4 terminologies that you would hear are simple cloud storage services, which basically is used for persistent data storage, such as storage of clinical data and storage of Jupyter Notebooks. It consists of Elastic Compute Cloud that is used to host Jupyter and Healthy Data Lab frontend. You'll also hear about Elastic MapReduce, which is used to manage the processing of data via Apache Spark. So it's kind of SQL. Relational database services, it is used for the Hive Metastore, which will organize the semi-structured data, which is found in simple cloud storage services. So Jupyter Notebooks, you must be familiar with the word. They are the primary means through which users access data, build queries, and program algorithms. And Jupyter Hub is a multi-user server that provides an interface for organization of Jupyter Notebooks. So these notebooks run on top of a kernel, and we can start and stop kernel. And this kernel is the actual computational engine, and that runs the code that needs to be executed within the notebook document. To give you an idea about electronic health records, strengths and weaknesses, I have borrowed this slide from one of the publications, and I truly present the slides in most of my presentations. I want to illustrate that ICD codes using ICD codes, it's easy to query, which serves as a good fit and pass for the disease status. But then there are some weaknesses in using these codes because these codes often are used for screening when disease is not actually present. So we need to carefully select our ICD codes. That's why the data requests that I get from Dr. Yifei and the team, they are very precise, and it brings greater strength to the study. And sometimes in using the codes, the accuracy could be hindered by billing realities and clinical workflows. Do you have a question?
No, they just needed to be muted.
Okay, excellent. So at the same time, if we use the CPT codes or the procedure codes, they bring very high precision, but then I have seen across different studies that it gives a fragmentation effect. I could go for my care, for my physician care in Kansas University Medical Center, which uses Epic, but then I could get a procedure done in Truman. So Truman doesn't have full picture of my care or all the comorbidities, but just the specific encounters that are pertaining to those procedures. So using CPT codes for identifying the cohort could be susceptible to missing data errors, which can be performed at that specific hospital. And sometimes certain procedure receipts influenced by patient and payer factors, which are external to disease process. But the greater strength is it's easy to query and it brings very high precision. The lab data, again, it gives high precision to us in these health informatics study retrospective analysis, but we might need to aggregate different variations of same data elements, and the normal ranges and units could change over time. The medication records, again, they're highly precise, but we often need to interface inpatient and outpatient records, and medication records from outside providers are not present in some of these electronic health records or these data warehouses. Medications prescribed may not necessarily be taken. Older version of health facts had a compliance status, but then it was retrofitted, it was removed in the subsequent releases of the data warehouses. Clinical documentation. So we need natural language processing in order to parse through the clinical documentation to have meaningful information, and that could add to the clinical care of a patient. But some of these electronic EHRs, these data warehouses, clinical documentation is not passed through because NLP is pretty complex and requires good amount of technical people to de-identify the documentation. But it is a good record, and it can give the physician's view of the care in those specific encounters. They are difficult to process automatically. Interpretation accuracy will depend on assessment method, and it could suffer significantly from cut and paste to some of these documentations. And it's not universally available in many of the EHRs. So as you can see, there are greater amount of strengths and some weaknesses to electronic health record data warehouse. Now, some of the recommendations for using aggregate electronic health records that I would like to make because after working for so many years in that field, they offer valuable resource to inform many type of research and quality improvement work. But then I have dabbled with the issues like missing data, and missing data happens because their origin in system implementations. They are based on local use of contributing EHR system. So missing data is a common concept in using this data warehouse, and sometimes we can impute data, or sometimes we can find certain averages or use the first or the last, use the index encounter or the last encounter, as long as we are presenting the logic with which we have identified our cohort, the logic with which we have refined our cohort, that we are including in the part of analysis, I think we are good and we can have meaningful deductions. This aggregate electronic health record data sometimes is not uniform at the temporal or content level. One of the examples is variations in workflow, such as reflex ordering of some lab tests or changes in clinical leadership and other factors. It could have similar effect on data. So some of these limitations are beyond technical sphere, like it's very difficult to address them because they are pertaining to implementation or they're pertaining to external factors, which are difficult to influence. In order to work effectively with the aggregate EHR data, it is important to understand that the attributes and characteristics of EHR implementation and to incorporate these methods that account for interfacility variation in the analysis plan. And also there is a need for any research involving aggregate EHR data to consider implementation factors that contributes to variability in data before attributing gaps to missing data. So for example, if I am doing a research study and the cohort could bring in data from 300 hospitals, another specific cohort, because of the very stringent inclusion criteria or one of the rare diseases, it could bring data from 25 hospitals. And the data, how the data is contributed by all these facilities varies humongously. Like some of the facilities could contribute good amount of diagnosis, procedures, labs, medications, but then vitals could be a limitation. So we need to consider the variability and we should not really come to the conclusion that because of the missing data and these specific limitations, or we could use surrogates in some scenarios. That is all for me to present. And I have truly enjoyed this group, working with this research group. And I open the panel, I open for questions here. Please feel free.
And I want to add that our group is open for potential collaboration. So Suman, could you talk a little bit about if someone in the audience wants to utilize any of the databases you mentioned, what are the procedures for them to follow?
Absolutely. First of all, I would like to mention, Dr. Yife, I have truly enjoyed working with the present team, and some of the procedures can follow. My email is given here on the slide. Please write to me once the idea that you have, so I could give you firsthand view about if we have the data elements pertaining to the hypothesis, pertaining to the proposal. Second, I'll expect you to submit a proposal to us. Once the proposal comes through, I do a feasibility analysis, identifying the number of patients and number of encounters across the number of facilities. And if that suffices your need, so initial 5 hours of consultation is free, not 5 hours of work, actually, when I work in data mining process. So I'm trying to keep the consultation separate from the technical time from when I mine the data. So I think from my department, I have gotten a green signal that I could give 5 hours of technical support, identifying the cohort, creating the cohort for you guys, free of charge. And after 5 hours, almost $79 per hour of my time can be written into grant or as a consulting. We prefer being written into grant, certain percentage of my time being written into grant, so it can support my salary. So the university can support these initiatives. It takes significant amount of dollars to have the infrastructure that houses the data, especially recently we have invested in Amazon Web Services with Piconet CDM, which has the data from MUHC. And we are using Snowflake. So the data analysis and deeper data analysis, a lot of computational support, a lot of computation depth has been supported by the infrastructure. So significant amount of dollars from the university are spent to support this infrastructure. So in short, please feel free to send me a proposal. I'll invest 5 hours of my technical support time in mining the cohort for you. The consultation exchange of emails, I'm keeping them separate from my technically working on your proposal. And after that, we expect certain small amount to be paid towards our services.
Thanks, Suman. I do know one question we have heard from a couple groups that we've been talking about the results of this analysis is when the 2019 and 2020 data could be mined and examined.
Absolutely. We can use Cerner real-world data for 2019 and 2020, 21, 22. Also, we could use MUHC data, which is right now IRB approval is underway. We hope that it will come back. It will come to us within few weeks, 1 or 2 weeks, or a couple of weeks, however fast they work because of the holiday season. But there are 2 sources. One is Cerner real-world data, and second is MUHC using Piconet common data model. Also, it can be, we can leverage GPC network, which brings data from many networks across 9 states. So that data is current as well. So three resources.
Thank you. So as we mentioned, we're talking about this in terms of a preliminary data to establish whether we would be able to do this analysis and what kind of outcomes would be detected, that we could come back and look at it from the perspective. I want to rewind us right back to the beginning of peer recovery support services. So, one of our hunches is peer recovery support services are potentially navigators, to fill in the gap between in the community and the services. We saw one of our results was that in the census region 4, there was less utilization of emergency services, inpatient and outpatient services. So that's an area of potential, gap that we could try to fill, especially for opioid use disorders with peer navigators. So I just wanted to bring that one point out for discussion, since I know you guys are primarily service providers. And then a couple minutes left, just, share that was one of the outcomes, longer term outcomes that we were hoping to examine with this data set analysis, but also other projects that we work on here in Kansas City, Missouri. And I don't know if Dr. Farr or Dr. Liu want to comment on that. I know people are probably going to be leaving for lunch in 3 minutes.
So as I mentioned, so this is a subgroup analysis focusing on the Midwest. We also have a larger study that examines all the geographic variability, and we hope to publish both.
Mm-hmm.
And I think now the awareness of using health informatics using data warehouse has been increasing with time. So lot of grant approvals, and this alongside bench-side research as well. I think health informatics is being looked at favorably as we get modernized in utilizing these electronic health records.
I love that, Suman. We want to make the data work for us, so that we can get to the areas of the communities that are most in need of our services.
And absolutely. And my ears were laden with frustration and happiness as well, where I was successful, and your group has been one of the very successful groups.
Oh, well, thank you. We've enjoyed working with you all. And I don't know, Ife or Stacy, if you want the closing remarks.
I mean, I was just going to add that, this, study and this use of this really, rich data was also led to through another project that I'm sure is being presented in a few other sessions, but which does utilize kind of the peer recovery coach model and how we had all kind of met and come together on this kind of spin-off project. But I did put the URL in the chat for anyone who is so interested, the kckvic.org or the Kansas City Quality and Value Innovation Consortium, which is part of the brand new UMKC Healthcare Institute for Innovations in Quality. So just kind of wanted to share and make everyone aware of that. You can sign up for our events and listservs and things like that there. But yeah, it's been a pleasure to work with this team in all capacities and lovely to present with you all. But Dr. Liu, do you have anything to end with?
Yeah, so as I mentioned earlier, we are open for collaboration. So if you are interested in any of the data sets Suma mentioned, please feel free to reach out to her. Also, you can reach out to our team, Dr. Hegel, Dr. Farr, or me, so we can chat further about future research ideas. Thank you.
Thank you.
Thanks.
Okay, thank you, presenters. I'm going to go ahead and end the recording now. And yes, everyone have a great lunch, and hopefully we'll see you back in this afternoon sessions.